An Implantable Cardioverter Defibrillator, or ICD, is a small device that can save your life. An ICD has two main parts: a battery-powered device, called the generator, placed under the skin, and thin wires, called leads, that go into the heart. These leads constantly monitor the heartbeat. If the leads detect a dangerous arrhythmia like ventricular tachycardia or ventricular fibrillation, they send a signal to the generator, which then delivers an electric shock through the same leads to the heart to restore a normal rhythm and prevent sudden cardiac arrest. ICDs are typically used in people who have survived sudden cardiac arrest or are at high risk due to weakened heart function from conditions like ischemic or non-ischemic cardiomyopathy, or certain genetic conditions like Brugada or long QT syndromes. There are different types: single chamber, dual chamber, and biventricular ICDs, each tailored to specific needs. Welcome to our presentation on Implantable Cardioverter Defibrillators, or ICDs for educational purposes. An ICD is a life-saving device for patients at risk of sudden cardiac death due to ventricular arrhythmias. It detects and treats life-threatening conditions like ventricular tachycardia or fibrillation, ensuring patient safety. ICDs consist of a battery-powered generator and leads that monitor heart rhythm. When dangerous arrhythmias are detected, the generator delivers a shock to restore normal rhythm. ICDs can also pace for bradycardia and provide anti-tachycardia pacing. ICDs come in two main types: subcutaneous ICDs, which have no leads inside the heart, and transvenous ICDs, which can be single, dual, or biventricular. Each type serves different patient needs and conditions. Subcutaneous ICDs are implanted under the skin without leads entering the heart, reducing infection risks. This reduces the risk of bloodstream infections and lead-related complications. They are primarily indicated for patients at risk of life-threatening arrhythmias who do not require pacing for bradycardia, cardiac resynchronization therapy, or anti-tachycardia pacing. They are particularly suitable for young patients, those with limited venous access, prior device-related infections, congenital heart disease, or long life expectancy. However, a major limitation is that they cannot provide pacing support, making them inappropriate for patients with symptomatic bradyarrhythmias or those needing cardiac resynchronization therapy or anti-tachycardia pacing. Single-chamber ICDs use a lead in the right ventricle to treat arrhythmias. They're suitable for patients who don't require atrial sensing or dual-chamber pacing, particularly those with reduced ejection fraction and intact AV conduction. Dual-chamber ICDs use two leads, one in the right atrium and one in the right ventricle, to provide both atrial and ventricular rhythm detection and pacing, enabling more physiologic pacing and enhanced arrhythmia management. They are indicated for patients who require atrial sensing or pacing, such as those with sinus node dysfunction or frequent atrial arrhythmias, in addition to ventricular arrhythmia protection. Ideal candidates include individuals with bradycardia, AV block, or other atrioventricular conduction abnormalities who need both pacing and defibrillation capabilities. However, these devices are more complex than single-chamber ICDs and carry higher risks of lead-related complications like dislodgement and infection, as well as programming challenges. Biventricular ICDs, also known as cardiac resynchronization therapy with defibrillator or CRT-D, use three leads placed in the right atrium, right ventricle, and left ventricle via the coronary sinus to synchronize heart contractions and deliver defibrillation therapy. These devices are indicated for patients with heart failure, a reduced ejection fraction 35% or below, and a wide QRS complex, especially those with left bundle branch block, to improve cardiac efficiency and reduce mortality. Ideal candidates include individuals with NYHA Class 2 to 3 and selected patients with Class 4 symptoms and evidence of ventricular desynchrony or conduction delays. However, CRT-Ds require precise lead placement and complex follow-up and are not appropriate for patients without electrical dyssynchrony or who are asymptomatic from heart failure. Indications for implantable cardioverter defibrillator placement are divided into primary and secondary prevention. Primary prevention refers to implanting the device in patients at high risk of sudden cardiac death before they experience a life-threatening arrhythmia, while secondary prevention involves ICD placement after a documented cardiac arrest or sustained ventricular arrhythmia. For primary prevention, ICDs are recommended in patients with ischemic cardiomyopathy at least 40 days post-myocardial infarction with NYHA class 2 to 3 symptoms and left ventricle ejection fraction of 35% or below, or NYHA class 1 with ejection fraction of 30% or below. Similarly, patients with non-ischemic dilated cardiomyopathy and ejection fraction of 35% or below with NYHA class 2 to 3 symptoms may qualify after at least 3 months of optimized guideline-directed medical therapy. Current AHA guidelines supports the use of CRT-D for some NYHA class 4 patients who are ambulatory and still have reasonable quality of life despite their advanced symptoms. ICDs are also considered in asymptomatic individuals with inherited arrhythmia syndromes such as Brugada if they are at high risk due to family history or genetic markers. For secondary prevention, ICDs are strongly indicated in survivors of cardiac arrest from VT or VF, not due to reversible causes, and those with sustained VT and hemodynamic compromise or sustained VT without syncope but with reduced ejection fraction below 40%. Refer to AHA-ACC guidelines for updates. Contraindications for ICD placement include life expectancy under 1 year, those with active systemic infections, which increase the risk of device-related complications. ICDs are also not recommended for patients with NYHA class 4 heart failure who are not transplant or CRT candidates, and for those within 40 days of a recent myocardial infarction or recent revascularization. Recent ACC and AHA guideline recommend CRT-D for some NYHA class 4 patients who are ambulatory and still have reasonable quality of life despite their advanced symptoms. Additional contraindications include reversible causes of VT or VF such as drug toxicity and electrolyte imbalances, severe psychiatric illness that impairs adherence or safety, and incessant VT or VF where alternative therapies are preferred. ICD implantation is performed under local anesthesia with sedation. Leads are placed via subclavian or cephalic vein, and the generator is positioned in a subcutaneous pocket. Defibrillation threshold testing may be conducted. ICD complications can be early, such as hematoma and infection, or late, like lead failure and inappropriate shocks. Psychological effects include anxiety and depression. This table looks at complications of ICDs in detail. Early complications include hematoma, presenting as localized swelling or pain, and managed conservatively or surgically. Superficial infections, indicated by warmth or drainage, treated with antibiotics or device removal if deeper. Pneumothorax, presenting with chest pain and shortness of breath, managed with observation or chest tube. Lead dislodgement is detected through device interrogation and imaging requires repositioning. Late complications involve lead failure, resulting in sensing or pacing anomalies. Inappropriate shocks from oversensing without arrhythmias, requiring device reprogramming or ablation. Device infections or endocarditis are marked by fever and positive blood cultures, which necessitate IV antibiotics and complete system extraction. Psychological complications include anxiety or depression, often triggered by fear of shocks, and post-shock PTSD, requiring counseling support or pharmacotherapy for long-term emotional well-being. Post-implantation monitoring includes wound care and chest X-rays to confirm lead placement. Routine checks occur every 3 to 6 months, with device interrogation to review arrhythmic events. Battery replacement is typically needed after 7 to 10 years. Device interrogation collects data on heart rate, rhythm, and device performance. A programmer communicates with the ICD to retrieve and analyze data, ensuring optimal function. Remote monitoring can also be utilized for ongoing assessment. In summary, ICDs significantly reduce mortality in high-risk patients. Careful selection based on guidelines is essential, and lifelong monitoring and patient education are key to successful outcomes. Next, let us test our knowledge with board-style questions. Question 1. This clinical scenario describes a 65-year-old man with ischemic cardiomyopathy, a reduced left ventricular ejection fraction of 28%, and New York Heart Association Class II symptoms, despite optimal medical therapy. According to current American Heart Association and American College of Cardiology guidelines, such patients meet criteria for primary prevention implantable cardioverter defibrillator placement. Question 2. Advanced metastatic cancer with life expectancy under 1 year is an absolute contraindication for ICD placement. The benefits of preventing sudden cardiac death do not outweigh the risks in this population. Question 3. This case describes a 70-year-old man presenting with palpitations and dizziness 1 week after implantable cardioverter defibrillator ICD placement. Device interrogation reveals failure to capture an abnormal lead impedance, while a chest X-ray confirms that the ventricular lead tip has migrated from its original position, findings that are characteristic of lead dislodgement. This complication typically occurs within days to weeks post-implantation and may present with symptoms such as palpitations, dizziness, or syncope due to ineffective pacing. Prompt recognition through device interrogation and imaging is essential, as early repositioning of the lead is critical to restore proper ICD function and prevent further complications. Question 4. This case illustrates a classic presentation of ICD lead-related endocarditis, a serious and potentially life-threatening complication that typically occurs months after device implantation. The patient presents with systemic symptoms including fever and weight loss, and blood cultures positive for Staphylococcus aureus, along with transesophageal echocardiography confirming a vegetation on the ICD lead. According to AHA, ACC, and HRS guidelines, the most appropriate next step is complete removal of the ICD system, generator, and leads, followed by intravenous antibiotic therapy. Simply treating with antibiotics without hardware removal risks persistent infection, embolization, and treatment failure. If you found this video helpful, don't forget to like, share, and subscribe for more content.